Hello, and welcome to your pre-lecture on musculoskeletal basics. I'm your faculty, Professor Brooks. Bones give form to the body, support tissues, and permit movement by providing points of attachment for muscles. Many bones meet in movable joints that determine the type and extent of movement possible. Bones also protect many of the body's vital organs. For example, the bones of the skull, thorax, and pelvis are hard exterior shields that protect the brain, heart, and lungs, and reproductive and urinary organs respectively. Within certain bones, the marrow cavities serve as storage sites for the hematopoietic system and stem cells that form both blood and immune cells. In adults, blood cells originate exclusively in the marrow cavities of the skull, vertebrae, ribs, sternum, shoulders, and pelvis. Bones also have a crucial role in mineral homeostasis, such as storing minerals, i.e. calcium, phosphate, carbonate, and magnesium. These minerals are essential for the proper performance of many delicate cellular mechanisms. They have a role in hormone homeostasis and assist in maintaining normal immunologic function. When we look at the image of a long bone, such as the one shown here, we can see much more is going on than expected. Bones are quite vascular, which facilitates oxygen and nutrient transport between bone tissue and blood vessels. To consider just how important this is, we will explore a femoral fracture. An adult femur can hold 3 to 4 pints of blood, out of an average of 8 to 12 pints total. Hemorrhage from a femoral fracture can be lethal. There are 2 types of bone marrow found in bones as well. Red marrow, the site of blood cell formation, which will be explored in the hematology section of this course, and yellow marrow, which is mostly adipose tissue. Bone consists of gelatinous combinations of glycoproteins in bone cells. Bone rigidity is primarily from crystallized calcium and other mineral components. This combination of minerals, collagen, and other proteins allow for the primary properties of osseous connective tissue, length and strength. These properties allow for weight-bearing activities. The images shown here are of an interosseous needle and catheter, often called an IO. This is a catheter used in the field or an emergency situation where vascular access is needed, but not able to be obtained efficiently through typical vascular access methods. This needle enters deep into the bone, where fluids and medications can enter the vasculature and be used in the body. The chemical composition and cellular components of bone is unique in that it creates new tissue as needed, rather than scar tissue after damage and repair. After receiving a chemical signal that bone repair is needed, osteoclasts resorb old bone, while osteoblasts lay down new bone. Some osteoblasts then convert to osteocytes, which become functional bone cells. A link here leads to a 3-minute video on bone biology and function. Bone remodeling is the process of turning old bone into new bone. In normal physiology, bone remodeling begins when rank ligand, otherwise known as rankle, a cytokine, is released by osteoblasts and binds to rank receptors on osteoclasts. Rankle is released in specific situations, like mechanical stress, such as exercise, to maintain quality when microfractures occur, such as when jumps out of a 2-story window, or when minerals such as calcium or phosphate are needed in the bloodstream. Osteoprotegerin, OPG, is released by osteoblasts once enough bone resorption has taken place, and blocks rankle from binding to rank. The bone resorption process is inhibited when OPG is released. This entire process takes 3 to 6 months to complete. A link here looks at the normal function of osteoblasts and osteoclasts. This slide contains another view of rank, rankle, and OPG and the bone remodeling process. This provides us with a better visual of where the cytokines act. Remember, rank is the receptor on the osteoclast surface. Rankle is released by osteoblasts to stimulate osteoclast bone resorption. OPG are the brakes to the bone resorption process. OPG prevents excessive demineralization or resorption. This image is a little analogy to help understand bone remodeling. You never knew you were going to be civil engineers when you went into nursing school. So this goes over some of the steps of how a long bone grows longer. These steps are occurring simultaneously in different regions around the cartilaginous growth plate. Cartilage cells are dividing and growing, and this is what adds length to the bone. However, cartilage cells then will secrete a chemical that calcifies the cartilage matrix. That chemical blocks nutrients, so those cartilage cells die, which leaves behind this space. Now there is some involvement with osteoclasts. They come in and they kind of clean up those dead cells, creating some space, because remember, osteoclasts break down bone or resorb bone. And then whenever we break down bone in a normal situation, osteoblasts come back in and secrete bone matrix. Those osteoblasts are building the new bone, and then to keep things in balance, osteoclasts will come back in to remove bone matrix if it's excessive. So we really can look at a construction kind of analogy here. Osteoclasts clear the pathway for a new road being built. Rankle promotes the clearing of that pathway. In order for those osteoclasts to work, we have to have rank ligand to break down the old dirt or the old bone. The osteoblasts are the people that put down the new highway. They're putting down new asphalt, they're painting the line, they're making sure the asphalt is flat. And OPG acts as the foreman of the construction crew. It will stop the osteoblasts from laying too much asphalt or the osteoclasts from taking away too much ground. We're going to look at this process one more time because I know students often struggle with this concept of chemical signaling, especially in bone remodeling. So we have our happy little bone producers, rank, rankle, and osteoclasts. Rank binds to rankle on the osteoclast surface to promote new bone growth. Okay, first we have to remove the old bone via osteoclasts, so then osteoblasts can rebuild healthy bone. The inhibitor, which to me is a great supervillain name, is OPG. OPG stops rank from binding to rankle and then reduces bone demineralization. Estrogen plays an important role in bone growth and repair. Estrogen limits the amount of rankle expressed. In the presence of estrogen, rankle is reduced, so bone loss is limited. However, with the loss of estrogen, rankle has free rein. It can lead to excessive bone loss. Therefore, post-menopause, bone loss is a huge risk. We're going to explore this in detail in our in-class lecture, but I wanted to give you these kind of previews of the information because I know students really struggle with this. Okay, let's leave bone absorption, demineralization, and reformation in the past for a moment and move on to the rest of the MSK system. So synovial joints. Synovial joints have a great range of motion. They contain a fluid-filled cavity or sac, called the synovial cavity, which lubricates the ends of two bones and allows them to move in various directions. Synovial joints make up most of the joints in our body. They consist of ball and socket joints, such as the shoulder and hip, which provide the most movement in multiple axes. Pivotal joints, such as the C1 joint, which allows for head movement in a rotational plane. Hinge joints, such as the elbow, allowing for flexion and extension. Condyloid joints in the wrist, allowing for flexion, extension, abduction, adduction, and circumduction. Plane joints in the tarsals, which allow gliding movements. And saddle joints, found in the carpal-metacarpal junction, which provides multi-axial movement, such as that of your thumb. These joints are the ones that are affected by rheumatoid arthritis and autoimmune disorder. In addition, the fluid-filled synovium can gain or lose synovial fluid, changing the mobility of the joint, and can become inflamed or infected as well. From our fluid and electrolyte lessons, we know that muscle is hydrophilic. Muscle is 75% water. It also contains 20% protein, with other various compounds completing the composition. With this kind of water reserve, we can see why someone with a lot of muscle tissue has less risk for fluid imbalances. Muscles function to accomplish work, and though that level of work varies, muscles do work in each of us. The byproducts of the metabolism needed to provide that work can be found in the bloodstream and are significant laboratory findings that can give us clues about body function overall. Our three main tests that fit this profile are creatinine, myoglobin, and lactic acid. Creatinine, as we've talked about, is a byproduct of normal skeletal muscle metabolism. When our kidneys are normally functional, this serum level remains relatively constant, except in cases of sudden extreme exercise. Myoglobin is typically released in cases of severe or extreme rapid muscle breakdown. This may be a crushing injury or from ischemia to skeletal muscle. Elevated myoglobin leads us to conclude that there is some injury to the muscle, but not a case of atrophy. As we know, these large proteins can overload the nephrons and lead to acute kidney injury or worsening of chronic kidney disease. Lactic acid is the end product of anaerobic metabolism in muscle tissue. Remember that lactic acid leads to pain. If you exercise or perform strenuous activities such as running upstairs, you may feel the burn, thanks to the lactic acid built up. When the body is starved for oxygen, such as in hypoxia and hypoxemia, related to sepsis typically, lactic acid is released by the muscles. Therefore, lactic acid is used as a marker for the severity of sepsis and other systemic ischemic events. Without training, muscle mass will decrease at a rate of 0.5 pound per year after the age of 30. This loss decreases metabolism and is the reason that as people age, they will gain weight without additional consumption of calories. This loss of muscle equates to adding about 1 pound of adipose per year. Sarcopenia is evident from age 50 and accelerates at age 70. This loss of muscle mass is due to declines in neuromuscular function and a decline in anabolic hormones, which encourage muscle cell growth. However, muscles are trainable, and sarcopenia can be delayed with regular activity. As the body ages, bone remodeling and mineralization take longer to accomplish. Bone resorption exceeds bone creation, especially in postmenopausal estrogen-dominant individuals. Estrogen typically decreases the ability of rankle to initiate the reabsorption process. When levels of estrogen decline, more rankle is available for stimulation of the rank receptor. This increases bone resorption, but not bone formation. We see an overall reduction in bone mass. By age 70, many estrogen-dominant individuals have lost 50% of their total bone mass. This can lead to pain, deformity, and severe fractures, limiting mobility and ability. Delay in the bone remodeling cycle also affects testosterone-dominant individuals, but later in life into a lesser degree, due to a lack of drastic hormonal influences, a higher bone mass, and a typically more physical activity. This once was the standard, but with modernization and progress, the once mainly physical labor performed by testosterone-dominant individuals is becoming less of an influence. Basically, higher bone mass, less estrogenic influence, and more physical activity set up an individual to have less bone mass loss with aging. Bone loss is increased in individuals who use tobacco, drink alcohol, have calcium deficiencies, and lack physical activity.